In 3, 2, 1. Please start, man.
Good evening, everyone. I welcome you all for today's webinar, Diagnostic and Treatment Options in Breast Cancer. With immense pleasure, I would like to invite Dr. Kaushik Kammar, Department of Medical Oncology, INHS, Ashwini Kolaba, for the welcome and introductory note. The stage is all yours, sir.
Yeah, thank you, organizers, and thanks for the opportunity. First of all, I welcome you all for this scientific discussion. So today we'll be talking about the diagnostic and the treatment options in the breast cancer. The breast cancer is one of the commonest malignancies which we encounter in our day-to-day practice, and the most concern is it is a heterogeneous disease and almost phenotypically it's a diverse disease with a different biological spectrum per se. So all different biological subtypes which have a different response to therapy and the outcome also. So today let's see it's interesting to discuss some of the diagnostics and then later on followed by some treatment evolutions in the management of the early breast cancer per se. So at the onset now I would welcome Dr. Amish Dalal, who will be speaking on the role of oncotype DX in the early breast cancer. Over to you, sir.
Thank you. Am I audible?
Yes, sir, you are audible, sir.
Okay. All right. So I thank you for this invite, and I'm happy to be talking to doctors from from the Ashwini Hospital and the Armed Forces. I've had a long association with many doctors from Ashwini during my days in Tata Hospital, and they were always happy memories. So it's a pleasure to be talking to you all now. So I'm going to see if I can share the content of whatever I have. Are the slides visible?
Yes, sir. Please start.
Okay. So the disclosure is basically that, as I've said, it's an honorarium that I've received from Advanced Meditech. And so far, as you all know, that breast cancer has been treated over many, many years in different ways. And as we have received more and more information through the years, that the treatment has evolved over the years. Initially, there was treatment where it was an empirical treatment. Many women underwent oophorectomy, and some of the women were found to have a response to the oophorectomy. Thereafter came the stage where we started treating patients based on the size of the tumor and the nodes of whether the nodes were positive or negative. Over a period of time, we got the estrogen receptors, progesterone receptors, and that is when we started bifurcating treatment based on the estrogen and progesterone receptors, while the tumor size and the nodal status still stayed the same. Soon after that, we got HER2, the HER2 new receptor, which again helped with the treatment, and more treatment came out based on that. That was the targeted treatment. And in such a way, the treatment has evolved of breast cancer. In spite of all this, there was never any way in which we could predict with certainty whether chemotherapy is benefiting these patients or not. And that is where we've found that in actuality, for early breast cancer, the benefit of chemotherapy or adjuvant chemotherapy is relatively limited. As you can see on this graph from the early breast cancer trialist group, that at 5 years, the difference between chemotherapy and non-chemotherapy arms was 3.5%. At 10 years, it was around 6%. So it's not a huge benefit. Of course, this chemotherapy was the basic CMF regime. And now, of course, there are many more stronger and more powerful regimes. We also know that chemotherapy has got multiple side effects. Some of them are the immediate side effects when the chemotherapy is going on. Soon after that, over the next few years, patients can have long-term side effects of chemotherapy. Alopecia persists, cardiac dysfunction is well known. Secondary cancers in a small percentage of patients is known to develop because of secondary to chemotherapy. A lot of women who are in their 40s may undergo premature menopause and have infertility along with it. And of course, with some of these newer drugs, you have peripheral neuropathy. In addition to all this, we also have seen that there is a definite affection of the quality of life. We have also seen that the family life is disturbed. A lot of families are constantly out with chemotherapy patients, and working life of patients who are undergoing some of these chemotherapies can be affected. They have to take leave. Now, a word about prognostic and predictive markers. Prognostic markers are those which are independent. The clinical outcome is independent of the treatment received. And predictive markers are the ones where the response to a specific treatment, the biomarker informs us of the response to the specific treatment. For example, if you have ER positive, then you know that dealing with hormonal therapy will have a specific response to that. And it predicts the response to the mark. The marker predicts the response to the hormonal manipulation. Adjuvant treatment decisions are often driven by prognostic factors, but only the few parameters are proven to be predictive of treatment response. We know that over the years, we have treated patients based on their nodal status, tumor size, tumor grade, and now, of course, we have started incorporating HER2 and ER and PR. We also have multiple gene assays, which are all, most of them are prognostic. Oncotype DX is one of those assays, one of the multi-gene assays, which we know that has found to be has initially was proven to be prognostic, but now we also know that it has predictive value. So just like ER, HER2, they are also predictive markers. Similarly, Oncotype DX has also been shown to be predictive. Well, we'll come to that as we go along in the further studies. The predictive marker for chemotherapy benefit was needed after this in the last few years to avoid extrapolation from the prognostic factors. So we would often extrapolate that the requirement for chemotherapy based on the prognostic features. But if the prognosis was not good or we thought was not good, we would say, okay, this person requires chemotherapy. It was never a more scientific, we needed a more scientific way of deciding whether some treatment like chemotherapy would be beneficial or not. So the recurrence score results we know now are predictive of chemotherapy benefit, and therefore we have been using it for the last couple of decades at least. So there are different kinds of multi-gene assays, but not all of them are the same. They need to give you enough information. They should be able to predict the benefit of chemotherapy. They should be prognostic. They should have a clinical utility. The prospective outcomes evidence has to be there to show that it is beneficial. And what is the level of evidence of some of these assays? And also how do we incorporate these assays into the treatment guidelines? Now, some of you will know that the Oncotype DX is a 21 gene assay, and it is used for predicting the chemotherapy benefit, and it is recognized or it has been shown to be for all N0 postmenopausal women and some of the N1 postmenopausal women as well, who are estrogen progesterone receptor positive while the HER2 is negative. So as you can see in this table, that it's a 21 gene assay. For those who are node negative, it is predictive as well as prognostic. And this is the preferred method by the NCCN. It is there in the NCCN guidelines. And the category of evidence is 1. Same thing for postmenopausal women who are having node positive disease, 1 to 3 nodes positive. Even in those, it has been shown to be predictive and prognostic, again with level 1 evidence. In premenopausal women, the level of evidence is little lower. It is at 2A. As in comparison, some of these other multi-gene assays, that is the 17, the MammaPrint, the ProSignia, the EndoPredict, these all are known to be prognostic, but the predictive value is not yet determined, and the level of evidence in all these is at 2A. The ASCO guidelines also are showing that Oncotype DX is an accepted and a standard test which is advised for all postmenopausal N0 and N1 disease, and for premenopausal women or less than women age less than 50 with at least node negative disease. For N1 disease, it is a something which is not yet in standard practice for premenopausal women. So the oncotype breast cancer score can support the treatment decisions. It can identify those patients who may derive benefit from the chemotherapy. It will also define the magnitude of the chemotherapy benefit, and it will support the treatment decisions because there is a visual and a numerical score which is there, which even the patients can understand a little easily. If most of you may have seen some report from Oncotype DX, and it's a very nice graph with the x-axis and y-axis showing the score and the percentage benefit, and that helps with making the patient understand that it's a good visual tool to make the patient understand this score. The Oncotype DX score is based on 21. It's a 21 gene assay, and we can see from this that 16 of them are cancer related and 5 of these are reference genes. These are basically classified into 5 basic groups and a group of reference genes. Some of the genes some of these things we are quite familiar with, but this is at a genetic level and therefore more likely to be more accurate. ER, PR, Ki67, HER2. So even those where we are not sure, they may be borderline HER2, here you might be able to get a more definitive answer. Of course, we try to do the FISH test first before we go in for the Oncotype DX. So this is the way the Oncotype DX is helpful. It is basically a newly diagnosed breast cancer. We have to see that they are ER and PR positive and HER2 is negative. And it may be N0 or N1 microscopic or N1 in postmenopausal. These are the patient group who will be advised Oncotype DX to a test to be done for the decision regarding chemotherapy. We know that these group of patients will require either breast conserving surgery or mastectomy followed by hormonal therapy. But whether they also require chemotherapy is the decision, or the decision is based on the Oncotype DX score. So the evolution of the Oncotype DX score or the test has been over many years. Initially, the validation was through the NSABP B14 and the trans-ATAC patients, where it was a retrospective analysis of almost 1,500 patients or so, where the Oncotype DX test was done, and that allowed the validation of the test. After that, the NSA-BP P20 and the SWAP studies, where they had almost 1,000 patients, where the prediction for the chemotherapy benefit was done. And again, this was on retrospective, the slides which were collected from there. And subsequently, the randomized trials of TAILOR-X and RX Ponder were done, where they had almost 15,000 patients for showing the chemotherapy benefit in selected patients. Yeah? So they had these two, so that there has been a progressive improvement and more and more data related to the Oncotype DX. As you can see in the NSA-BP B20 study, that in the patients who had an Oncotype DX score of 0 to 10 and 11 to 25, there is no chemotherapy benefit. Both the graphs are absolutely identical, overlapping each other. And where the score was 26 to 100, there they could see that there is almost 26% absolute chemotherapy benefit. So you are super selecting patients from those who are hormone receptor positive and HER2 negative, and only a small percentage of these patients will really end up having these scores which requires chemotherapy. And you can see based on this, the recurrence score predicts the chemotherapy benefit interaction as the p-value of 0.014. Similarly, in the SWOG study, here they had a different cutoff of the score. So this was one of the studies where they had a score where 0 to 17 was considered as no significant benefit of chemotherapy. 18 to 30 was the intermediate risk group. And in that, you can see again, the graphs are overlapping, but the p-value is 0.89. A word about this is that in this group of patients, 18 to 25 was taken as the low intermediate score, and 26 to 31 was taken as the high intermediate score. So there was always this question about whether those with the high intermediate score should be given chemotherapy in addition to the hormonal therapy. So this group, that's the reason why there is not as much shown benefit, because of the big interval in the score. And of course, those who were more than 31 obviously had a high absolute chemotherapy benefit of almost 19%. Then we come to the TAILOR-X study. And in the TAILOR-X study, as you can see that those patients, these are in this graph, you can see this is the N0 patients. And in the results of the 11 to 25 score, there is absolutely no difference in the in the chemotherapy versus the endocrine therapy group. In the same thing with the TAILOR-X, where you have N0 and where they've taken the whole group of patients from 0 to 25. And as you can see, there are three lines, three graphs, which are three groups which are overlapping. And those groups are the RS, the recurrence score 0 to 10, RS score 11 to 25, which was randomized to endocrine therapy alone, and the recurrence score 11 to 25, which was randomized to chemoendocrine. And only the purple line you can see where there is a benefit, and that is for the group with the 26 to 100 score. In the RX Ponder group, the node positive postmenopausal with a recurrence score of 0 to 25 also did not show any benefit. As you can see in the left-hand side graph is the postmenopausal group with even with N1 disease, there is absolutely no benefit of the chemotherapy. The graphs are overlapping. While in the premenopausal group with the 0 to 25, the whole range, there is a almost 5% benefit with the chemotherapy. And therefore, in the premenopausal at this point of time, those with node positive would be given chemotherapy. So this is a table which essentially shows you that the different groups where the percentage of chemotherapy benefit is there. Those who are in the more than 50 age group, there is no chemotherapy benefit till the age of till the score of 0 to 25. And 26 to 100, there is a substantial chemotherapy benefit. In those who are less than 50 years old, and who are node negative, there is no chemotherapy benefit until the score, the recurrent score is 11 to 15 till 15. From 16 to 20, with a node negative, there is a 3.1% chemotherapy benefit with a 7.8% chemotherapy benefit if the score is 11 to 25. So in those who are less than 50, with a little higher score in that, there is a substantial chemotherapy benefit. In the premenopausal who are node positive, there is a chemotherapy benefit in all the groups. Although the chemotherapy benefit in those who are between 0 to 13 is only 2.3%, but in the higher scores, the benefit is 2.8% and more. So Oncotype DX test consistently identifies a majority of the hormone receptor positive, HER2 negative, N0, N1, postmenopausal who can avoid chemotherapy. As you can see in this, that whenever the test is done, almost 80 to 85% of patients you'll see that there is no chemotherapy benefit. 15 to 20% of patients will have a substantial chemotherapy benefit. In other words, you're choosing a very small, out of 100 patients who are with this report, at least only 15 to 20% of patients will be benefiting from the additional chemotherapy. So the decision impact, so the risk of over-treatment with these, doing the test, it comes down, it comes down to about 70%, 70 odd percent, and the risk of under-treatment is somewhere in the range of 9 to 10%. So you're super selecting patients with the testing. So the two big trials of TAILOR-X and RX Ponder have had almost 15,000 patients. And you can see in this table that on the left-hand side are the validation studies where the number of patients was somewhere around 1,500. Then you had validation studies of NSA, BP, B20 and SWOG. And here you had about 1,000 patients, including some who were in the SWOG study. They had taken, most of them were all node positive patients. And then you had 3 randomized controlled trials where you had the Plan B, TAILOR-X and the RX Ponder. RX Ponder had patients who were all in the node positive group. So overall, there is a huge body of evidence which is based on which this test has been shown to be beneficial. It has been ratified by multiple societies, the NCCN guidelines, St. Gallen, ASCO, NICE, ESMO, a lot of them have shown to be have ratified this. So Oncotype DX score is the standard of care to help adjuvant chemotherapy in early breast cancer. It's the only assay proven to predict chemotherapy benefit. It's an independent predictor of chemotherapy benefit and patient outcomes. It can help to reduce over and under treatment, and it can help guide treatment decisions across the age groups. Consistent with the large body of evidence across prospective randomized trials and the validation studies in the early world experience. Now, TAILOR-X, I think a lot of y'all may have already seen the paper on the TAILOR-X. I will just briefly go through some of the data of TAILOR-X, which will highlight the things. As you can see in the TAILOR-X, they have chosen a specific group of patients who are at the recurrence score of 11 to 25. And in that, they had the experimental arm where they had only endocrine therapy, and in the standard arm where they had endocrine therapy and chemotherapy. The randomization factors were based on the menopausal status, the planned chemotherapy, planned radiation, and recurrence scores. So endocrine therapy alone was not inferior to chemoendocrine therapy in the recurrence score group of 11 to 25 for the invasive disease-free survival as well as the distant recurrence-free intervals. So in this, the other thing is regarding from the trial, the chemotherapy benefit in the women who are less than 50 years and a recurrence score. As you can see, they have divided it into different groups. You can see that the recurrence score 0 to 10, there is no benefit. 11 to 15, there is almost no benefit. You can see the green and the gray bars are identical. In the recurrence score, between 16 to 20 score, there is a 1.6% benefit in the distant recurrences. While in the 11 to 25, it is 6.5% benefit for chemoendocrine therapy. And of course, for 26, it is always chemo and endocrine therapy. So what they have also clarified is that even though statistically these differences in the distant recurrence were not statistically significant, they may be clinically significant. So in my practice, I might say that those women who are less than 50, I would give chemotherapy to those who are between the scores of 21 to 25. The 11 to 20 may not give chemotherapy unless they have some high risk clinical factors, for example, large tumor size, and it is grade 3 on the initial pathology report. So otherwise, they by and large, the 21 to 25 are more likely to receive chemotherapy and when they are less than 50 years old. So this is again a similar thing. This is the where the clinical risk adds insight into the chemotherapy for those who are less than 50. So they have added one more criteria, where if it's a low risk clinical disease, indicating therefore that clinically the lump is not very big, it is say a 1.5 centimeter lump, and it is a grade 1 or grade 2 tumor. And in spite of that, if you get one of these recurrent scores, then if it comes under low risk, low clinical risk. While if it is a high clinical risk and the recurrent score is 16 to 20, the benefit is about 1.6% or maybe higher. Maybe 6.4 is what they have claimed here. While in the low risk but higher score, 21 to 25 score, with a low clinical risk, the benefit is 6.4%. With a high clinical risk, the benefit is 8.7%. So essentially, the 21 to 25 score gets a benefit if they are less than 50 years old. And so they had an update of the TAILOR-X study, and in that they have again essentially given us more data at 12 years. And they have said that the distant recurrence is around 7% at 12 years in both the endocrine therapy and in the chemoendocrine therapy arms. Late recurrences outpaced the earlier recurrences. So by and large, there was not many recurrences or no recurrences in the 5 years, but between 5 and 12 years, the late recurrences would come up. Similar pattern at 5 and 12 years for recurrence-free interval and for disease-free interval. No recurrence events at the non-recurrence events at 1% per year calculated at the difference between the invasive disease-free survival and the recurrence-free survival. Most of the deaths, as we said, occurred after the year 5. Rates of overall survival are similar in both endocrine therapy and chemoendocrine therapy. So this we already discussed, that there is an increasing benefit of chemotherapy with increased recurrence scores in those patients who are less than 50. And the same thing is here, that the effect of age and the recurrence score and the clinical risk. You can see from this table on the right hand side that the benefit for those who are is around 3.1%, 5.9%, and 11.7% as the scores increase or the clinical risk score increases. So in conclusion, for the TAILOR-X, so the longer median follow-up and more events in the randomized group, the median was 11 years versus 7.5 years. And the invasive disease-free survival, there were more events obviously in the longer time frame. And same thing with the disease distant recurrence-free interval. There was 375 versus 250 events. And the main study findings were unchanged for the group between 11 to 25. The endocrine therapy was non-inferior to chemoendocrine therapy for the invasive disease-free survival and the distant recurrence-free interval. The recurrence-free interval and the overall survival were similar in between the treatment arms. So the exploratory key study findings were that some chemotherapy benefit for patients who are less than 50 in the recurrence score of 21 to 25. And some chemotherapy benefit for less than 50, 16 to 20 score with a high clinical risk. So this is from the Sears database, which was, again, it's a retrospective data collection, where they have seen that all through the scores, the at 9 years, the recurrence-free interval remains as 98, 99, 96, 93%. Even though the scores are increasing, they are all in the high 90s. And finally, between 26 and 100, you see a sudden drop in the long-term survivals and the recurrence-free intervals. I think that's where my talk ends. I'm happy to answer some questions related to Oncotype DX. Hello.
Yes, sir.
I'm happy to answer any questions related to Oncotype DX.
Yeah, the house is open for questions. If any questions are there, please can put it on the chat box or can just unmute and speak to the speaker itself.
Was it reasonably clear or was it too
No, no,
fast, too
the
confusing?
talk was excellent, sir, and you almost covered the entire aspect of oncotype, including the RX model and the Taylor study. So we'll take some few questions in the panel when we speak of this test,
Okay.
and we'll go ahead with a further presentation, sir.
Okay. Thank you very much.
Thank you for the talk, sir. Thank you.
Thank you.
So the next talk will be me. I will be covering on the evolving evidence and management of the patients with HR positive early breast cancer success particularly. I hope my slides are visible and I'm audible at present.
Yes, sir. Please start.
So these are my disclaimers and the slides have been provided by the Novartis. So we know that the treatment options for the early breast cancer mainly comprising stage 1, stage 2A, stage 2B, a particular subtype T2 element disease. And over the last few decades, maybe the last 2 decades, the treatment per se has not been changed much. Like we know after the initial definitive local treatment comprising of the surgery, either BCS or mastectomy followed by the RT, few patients are lined up in chemotherapy and majority in endocrine therapy with extended duration of up to 5 to 10 years and followed with the follow-up throughout the time. So here, the last 2 decades, almost the treatment remains static in this particular subset of patients with some improvement in the endocrine therapy subset where we had tamoxifen. Initially, it was only the surgical oophorectomy, and later there was the estrogen receptor modulators with tamoxifen, later raloxifene, improvement in the aromatase inhibitors with anastrozole, letrozole, and exemestane coming up in the early 20s. And then a few improvement in the GnRH analogs particularly. Other than that, overall, the majority of the treatment landscape remained almost static throughout the last decade. And even the major guidelines also, the management of early breast cancer, it was almost the the flowchart was simple. Like early breast than tumor less than 2 centimeters can be operable. Usually go and first into the surgery and then later on the treatment aspects either radiation followed by the chemotherapy or adjuvant how to direct the therapy in those subset of subjects. And those with HER2 positive or the TNBC tumor, larger tumors usually go for the NACT and later followed with the surgery followed with the adjuvant chemotherapy. So even for the hormone positive subset particularly, it was fairly the same. Though they were divided to luminal A and luminal B, majority they would have landed up with only endocrine therapy and chemotherapy in only high, but those with the high burden of the disease would have been fetched up in the chemotherapy first step. So no major changes per se in the management guidelines in the early breast cancer. And the same was echoed with the major guidelines also in the ESMO and NCCN. We have the endocrine therapy options of both the tamoxifen and aromatase inhibitors. Some advantage of AIs over the tamoxifen, in particular those patients with less than 60 years of age and those with having the concerns of thromboembolism per se. And it has been seen that the aromatic inhibitors had a benefit of around 2% benefit in the DFS, and the overall survival there was almost equivalent. It was same in both AI and tamoxifen subsets. And I actually also it was seen that the extended use of endocrine therapy, it was seen the advantage of 10 years or the 5 years for the usage of aromatic inhibitors. And though the DFS benefit was almost same even after the use of tamoxifen, either the aromatase inhibitors can use upfront or sequential or concurrent therapy. So, majorly it was the clinical and the pathological prognostic factors like the tumor size, grade, nodal involvement, and the case it is a question as thought of, which identify the high risk patients who are the candidate of adjuvant chemotherapy. But again, it was not the criteria was not that common. It was agreed upon by the multiple guidelines. Even though these were the standard protocols, there was a huge unmet need in these subset of early breast cancer patients, mainly because of the risk of recurrences. We can see in this graph depicted left side, as the nodal burden increases with the end of adjuvant endocrine therapy, the risk of distant recurrence also increases. Like those with N0 disease can take a 10-year distant recurrence is around 10%, and those with N1, N1 to N1 to 3 nodes, it was around 20%, and those with more than 3 nodes, the risk of recurrence after the end of adjuvant therapy at 10 years is up to the tune of 30 to 40%. So, this was the unmet need basically, how to prevent the risk of recurrences even after giving the adequate adjuvant therapy, even after the extended duration of adjuvant therapy. And prevalence of patients who were receiving chemotherapy, mainly it was the node positive subset who were receiving chemotherapy per se, compared to the node negative subset. Though the chemotherapy was effective in reducing the risk of recurrences, but the issue was with the toxicity, and there was more of effort which has to be required to de-escalate the treatment and re-examine the benefit versus toxicity, and how we can reduce the over treatment of these patients particularly. Another most important issue with the endocrine therapy was the non-adherence to endocrine therapy because of the prolonged duration, and it resulted in a significant increase in the risk of DFS event. So it was one of the studies which has showed that the disease survival comparison was seen in a patient who had at least 54 months of endocrine therapy, either tamoxifen or letrozole, based on the compliance, whether the compliance was more than 90% or less than 20%, yeah, less than 90%, and showed that there was almost 61% increase in the risk of future disease survival even if the compliance was less than 90%. The less the compliance, the risk of events. And also the major discontinuation, why the compliance was less than 90%, the study showed that the major treatment early discontinuation was because of the symptomatic adverse events up to the tune of around 80%. And so it was said that the non-adherence resulting in the discontinuation resulted in this impacted the clinical benefit and resulted in the treatment resistance, disease progression, and death per se. So it was important to ensure, to critically to ensure that the adherence is important in endocrine therapy to also to minimize the symptomatic adverse events and to maintain the efficacy per se. So, the last half a decade, then we saw some improvement in the management in the early breast cancer, particularly talking to the hormone positive upside, was the incorporation of the PARP inhibitor, olaparib, particularly in a subset of patients who were BRCA positive, and adjuvant CDK4/6 inhibitors, those with high risk positive, based on this monarchy data. We will talk about in the first side. So, we will stick to the presentation, particularly to the CDK4/6 inhibitor, the adjuvant setting. So, what was the rationale per se for the use of CDK4/6 inhibitors in the early breast cancer? So, based on one of the hallmarks of the cancer, the carcinogenesis is senescence, which is known as a complex state of growth arrest, which is usually triggered by the cellular stressors. So, this senescence results in a dormant micrometastasis to prolong from years to decades to remain in the cancer stem cell. So, what required is the immune activation. It helps in clearance of these senescent cells. So, how the CDK4/6 inhibitors help are? One is it has been shown that the CDK4/6 inhibitors they downregulate the cell proliferation and resulting in the cell cycle inhibition. Also, these inhibitors they drive a senescence response in the preclinical samples which have been studied and also helps in increasing the T cell subsets and upregulation of the immune activation in the clinical samples. So this combination of the CDK4/6 inhibitor along with endocrine therapy has been shown that it arrested the dormant micrometastasis to evolve into the macrometastasis, resulting in the better control of the macrometastatic disease. So, also the pattern of recurrences in the early stage hormone positive disease, because it was seen that there were two types of recurrences, particularly it can broadly divide early recurrences and the late recurrences. So, in all the stages of the disease, the early recurrences I was seen was driven majorly by the replicating cells per se, and the late recurrences are usually by the dormant cells because of the cancer stem cells or the dormant cells per se. So the role of the adjuvant erythropoiesis inhibitors was more important in the initial replicating the cells to prevent the early recurrences, and it was also studied in all the major trials comprising the three CDK4/6 inhibitors. We had the Phenolip trial for the palbociclib, which was used after the neoadjuvant therapy in those with high risk of recurrences, and Monarchy had abemaciclib mainly in the high risk pathological factors, and Palas tried palbociclib in majorly the stage 2 and stage 3 disease, and Natalie had a ribociclib trial which majorly in the stage 2 and stage 3. So these were main targeting the replication cells to prevent the early recurrences mainly. So these were the major trials which evaluated evolved the role of adjuvant inhibitor. So what was the all the trials same or was there any differences? Majorly, even though the inclusion of criteria, the pre and post menopause was same in almost the Palas majorly, Palas Monarch and Natalie trial comprising around 5,000 patients subset. So it was heterogeneous in the selection of the disease population based on the disease severity. Majorly in the Palas trial, it was all the subset of stage 2 and stage 3 disease from N0 to N3 were included in this study. And Phenolip, it was majorly the neoadjuvant patient who had residual invasive disease after neoadjuvant therapy, and they need this probability factor of CPC score of more than 3 to select a patient who choose to fit for this Phenolip group. And in Monarchy, they had two cohorts. One cohort first of all more than those patients who had more than 4 axial lymph nodes or 1 to 3 axial lymph nodes, either with a tumor size of more than 5 centimeters or grade 3 subset, or a cohort, the another cohort was 1 to 3 axial lymph nodes with a KS inclusion of more than 20%. So this was in Monarchy inclusion criteria, and Natalie had a stage 2B, stage 3 N0N1, stage 2B of both N0N1 and stage 2A, including the N1 patient. Here it was in the stage 2A, those with N0 also, either with a grade 3 patient or N0 with a grade 2 of more KS of more than 20% were included in this subset of Natalie population. So, and the dose was almost same except for the Natalie, where the ribociclib was used in the reduced dose of 400 milligram once a day, the 3-week on and 1 week off schedule. Other than that, the remaining doses were the same as used in the metastatic setting. So duration of the therapy also, the Palas used palbociclib for 2 years of adjuvant, and Monarchy had a abemaciclib for up to 2 years, and Natalie had a extended duration of adjuvant ribociclib for the 3 years duration. So you know that the cross comparison is not actually we are not possible to directly head to head comparing the subset of patients. We have seen that in Monarchy, we see in the stage 2A group, a high risk as per Monarchy was majorly any N2 or N3 in the stage 2 and stage 3, or any N1 if it was a grade 3 or tumor size of 5 centimeter or KCT7 of more than 20. In the Natalie subgroup, so it included all these patients who were included in the Monarchy and beyond, particularly all the stage 2, stage 3 that go with those with N1, N2, N3, were extra included in the Natalie subgroup. And additionally, also it included those with N0, but with those tumors with grade 2 and high genomic risk, or either the key mutation of more than 20%, or grade 3 tumors, even if it was N0 and T3 or T4 subset with N0, were included in the Natalie subset. And in Palas, again, it allowed everyone from N0 to N3 in stage 2 and stage 3 disease was included in the Palas trial. So what happened since initially it was the benefit was seen in the Monarchy abemaciclib group. There was a real world interesting paper which was put up one by the Dan Faber Cancer Center. It was seen that They had evaluated the patient in the patient database around 5,000 patients which are positive early breast cancer patients. They have seen that those patients which were eligible for these abemaciclib inclusion criteria, it was only to the 11.1% they're only eligible as per the eligibility criteria based on the monarchy subject. And another one was for the extensive seed database analysis, where around 238,000 population in the seed database was analyzed, and the only it was seen that only 12% patients met the monarchy criteria, and those who did not meet, around 13% were of stage 2, stage 3, no positive disease, but they could not be enrolled based on the strict criteria by the monarchy. Overall, it was around 11 to 12% of early breast cancer patients who would have been included as per the eligibility criteria of the monarchy. So, another interesting over here, what happened was the PALAS and the Pinula trial, which showed that there was no benefit in the subset of patients with HR positive HER2 negative early breast cancer who were treated with palbociclib with endocrine therapy in adjuvant setting, even with extended follow-up by the Pinolop B arm, which confirmed there was no benefit with the both the trials. The PALAS was a negative trial, and the extended follow-up of the Pinolop B and neoadjuvant after the neoadjuvant high-risk population also confirmed so much of benefit in this subset of population. And even in the subgroup analysis of this trial of the palbociclib was saying that even those with the higher stage, the stage 2B or stage 3 disease, or with higher nodal burden per se, or their own risk categorization with the CPS score which they have gotten, they have that the inclusion was CPS of more than 3, or those who had the high grade disease. In either of the subgroup, there was no much of a big benefit with the individual survival with the palbociclib arm compared to the endocrine therapy arm. So then there came to thought process, why did the CDK4/6 or particularly the palbociclib fail? So the first hypothesis which was brought out was the high discontinuation rate up to the tune of 44%, which was seen in this trial, suggesting a suboptimal drug exposure. They said that the protocol was very strict regarding the dose reductions or the dose holding for the grade 3 neutropenia, which is the most common cause for the discontinuation. Whereas in clinical practice, usually with the advances in metastatic setting, the palbociclib need to continue with the dose reduction in this situation. However, in the trial, they were all discontinued or excluded with the high discontinuation rate was seen. But again, the further analysis refuted this hypothesis, saying that when the last 24-month follow-up landmark analysis, which showed that patients who did receive complete pre-planned treatment versus those who stopped palbociclib early because of the discontinuation, there was no much difference, and the lack of individual disease survival benefit. Either the who completed and the discontinued, there was no much of difference. So it refuted the high discontinuation hypothesis which was seen, and even in the phenolepry, which investigated the adjuvant 1 year of palbociclib versus only placebo for the high risk disease, it also showed that there was no individual disease survival benefit observed for the palbociclib after a median follow-up of 42 months in the set of patients. So, other hypothesis which was seen that the patient in the PALAS group had a lower risk of recurrence. So, but again, it was repeated because the high risk subset of patients made up to the 59 to 60% in PALAS trial, and there was no benefit seen with the addition of palbociclib in these set of patients compared to the low risk patients in the PALAS trial. So, this hypothesis also repeated that major of the patients were low risk. Here, the high risk subset of up to the 60% were included in the palbociclib arm. So then the landmark data was from the actually the monarchy data, which had a significant and consistent individual disease survival benefit throughout. You can just see the hazard of the individual disease survival for the abemaciclib with the endocrine therapy versus the endocrine therapy. In the initial interim analysis, the hazard was at the 0.75, and gradually, as the analysis, as the study progressed, we can see that the 2020, the primary outcome, the hazard was 0.71, and additional follow-up a year later, hazard improved with a 0.69, and the latest SABCS 22 update, we can see the hazard of 0.66. You can see the 2-year individual disease survival rate was initially it was 2.8%, and the third year it improved to 4.8%, the delta, and the 4-year delta was to the tune of 6.8%. It was 85% of invasive disease survival benefit versus 79% in the endocrine therapy arm. So, and the benefit and the extended follow-up of up to 48 to 42 months of median follow-up duration, with a hazard of 0.66, there was almost 36, 33% reduction in the risk of development of a invasive disease survival event in the abemaciclib endocrine therapy arm. And with the absolute benefit of around 6.4% of the 4-year absolute benefit, and also the 2-year and 3-year benefit were compared and it persisted and it continued giving the benefit. The benefit was also consistent with all the pre-specified subgroup, which was the subgroup which they thought of high risk and would benefit from CD46 inhibitor. All the subgroups, including the grade 3 disease, tumor size, those who had premenopausal disease or the postmenopausal, and even the tumor state, all the subgroups consistently had a benefit with the use of endocrine CDK4/6 inhibitor, particularly abemaciclib. Then there was the last one which we had left was ribociclib. So they came an Italy trial. So it was a phase 3 trial of aromatase inhibitor with the ribociclib, the control of comparator arm towards the only endocrine therapy. So what was the rationale for the? You can see initially as we discussed in the slide, the inclusion was more of a widespread to the Italy arm. So the rationale for broad population was patient with stage 3 or stage 2 in early breast cancer, including those with nodal positive or nodal disease at risk of disease, they had a recurrence up to decades after the initial diagnosis. So broaden the inclusion criteria, more of a patient were included this natalitol. And the ribociclib dose, as we said, it was reduced from 400 to 600, mainly to improve the tolerability and to at the same time to maintain the efficacy. And the rationale for here, the abemaciclib was used for 2 years in the adjuvant, and ribociclib they used 3 year treatment duration, particularly so that the extended duration of treatment was crucial to reduce the chance of recurrences and also to prolong the cell cycle array, drive more tumor cells into the irreversible sinus and death. This was the rationale which was given for the 3-month, 3-year extended duration of ribociclib. So this was the interim analysis which has been seen. The ribociclib, the individual disease survival, the interim analysis of median 27.7 months with a hazard of 0.74 was seen that the absolute the benefit was to the tune of 3.3% at 3 years with a significant p-value and hazard of 0.74. So at 3 years, we had up to around 22 years, it was 57% who were ongoing treatment, and 3 years, the patient who had completed the ribociclib treatment was around 20%. And across the key subgroups, considering the highest stage, those who had prior chemotherapy or no, or the key 6-7 index, almost all the subgroups had a benefit with the invasive disease survival as per the this interim analysis. And also the distant disease survival also improved with the ribociclib as per the interim analysis, where the hazard was around 0.73 with a p of with a significant p of 0.017. So it was seen that at 3 years the distant disease survival benefit was to the tune of 2.2%, with the risk of distant disease reduced to the tune of 26% in the ribociclib arm compared to the only endocrine therapy arm. And coming to the just similarity, now we have seen the three major trials evaluating the role of CDK4/6, last Monarchy and the Natalie. So coming to stage of the patients which had been used for study population, in Monarchy trial in abemaciclib, majority around 75% patients were in the stage 3, or in that majorly around 33% were in the stage 3 disease, that is NET or N3 population. But however, in the ribociclib and the palbociclib, the Natali and Palas trial, fairly the population was almost equal initially, was to the tune of 60% or 50%. And the nodal status also, the Palas and the Natali had a similar spread of nodal status, but Monarchy had a significant higher population of those patients who had more than 4 positive nodes. And even the grade of the patient were similar in all the three trials. And coming to the missing data, like the Monarchy patient, there are 95% had received prior chemotherapy, prior either in the neoadjuvant setting, they had received in the Monarchy subset trial. But the Natalie and Pala, the rate was a bit on lower side, 85 to 88% who had received the prior chemotherapy, showing that the difference in the severity of the disease in respect to trial population was have a slight of different particularly. And though again a cross comparator was not allowed, this is the overall the bird side of the compared to description of the three CDK4/6 inhibitors in the early breast cancer trial, which was seen that 3 years you can see the median follow-up of 27 months. The invasive disease survival with Natalie was around 0.75 hazard, and similarly it was around the tune of 0.70 in the monarchy, but Palas was again a negative here with a hazard of 0.93, and overall survival, it was immature at present. Still, there was seen to be have some clinical benefit, but at present, the results are still immature, and not much of analysis can be done because of the immaturity of the results with Natali and Penelope, which was a negative trial. But Monarchy, majorly the OS here was based on the invasive digital survival follow-up. Some benefit with the Monarchy, they have data coming up with the overall survival benefit. And coming to the safety profile, ribosacin was fairly tolerated. Majority side effect was neutropenia, as we have seen with the usage in the metastatic breast cancer. And that was the most leading to the discontinuation was one was the liver-related adverse event, which was seen to the tune of 9% in those with the ribociclib and arthralgia. And majority of the discontinuation was seen in the ribociclib was in the early period. It was within the start of 4 months of therapy. The ribociclib and compared to the dosage, 400 versus 2 milligram, the safety profile, was seen that those receiving the lower dosage of around 400 milligram, the there was a dose dependent toxicity, particularly the neutropenia. You can see that already even neutropenia was around for 74% in the 600 milligram, whereas it was around only 62% in the 400 milligram subset. So it was well tolerated, this 400 milligram subset. And even the QT prolongation, no much of QT prolongation, the 400 milligram, it was like 6.5% in the 600 milligram versus 4% in the only the 400 milligram subset. It was well tolerated, coming to the side effect was the 400 milligram. Safety profile, because in the palbociclib, there was data from the Palas and Pinolog, it was consistent as we have seen in the advanced breast cancer setting. However, the rate of major of the side effects were myelotoxicity with the neutropenia, leukopenia, and fatigue, and the discontinuation rate was very high to the tune of almost 42% in the Palas and 18-19% in the Pinolog arm. In monarchy, again, the safety data, which we know the major side effects here is the diarrhea, infections, and neutropenia. And the discontinuation arm in the abemaciclib was to the tune of around 16%. And it was well tolerated except for the diarrhea and fatigue and arthralgia. And the discontinuation rate, this is a snapshot view, all the 3D because we can see the Palas, the discontinuation was very high, 27%. But in abemaciclib was well tolerated with a median follow-up of 23 minutes. Here, the discontinuation was only to the tune of 18%. And in Natalie, it was around to the tune of 19%. So well tolerated, both the CDK4/6 and again, snapshot view, no major comment on the cross comparison study, but we know that the benefit of invasive disease survival, uh, palbociclib being a majorly negative, monarchy, the 2 year benefit to the tune of around 92% versus 18%, a significant benefit in the invasive disease survival. Again, in Natalie, a 3 year benefit showing a 90% versus 87%. Persistently, both the ribociclib and abemaciclib having the benefit in the invasive disease survival with the use in the adjuvant setting. So, just coming to the end of this talk, we have seen that the early stage HR positive disease is it has a risk of ongoing risk of relapse over the time. With the highest peak of relapse is usually seen in the first 2 years, but it has been seen that in the studies that the risk persists beyond the 2 to 5 years bracket also, and significant risk of distant relapse seen in those with node negative also it has been seen in limited node positive subset of breast cancer. And the abemaciclib, we have the data evolved, and adjuvant abemaciclib with endocrine therapy, which has shown to significantly reduce the risk of distant relapses in high risk cohorts. And however, the palbociclib failed to show any benefit. And the data from the Natalie, the ribociclib is encouraging as per the interim analysis of invasive disease control improvement. So the challenge for us is to how do we optimize the newer therapy option which we have with molecules in a patient based on the risk of recurrence, long-term efficacy, and safety of endpoint. So with this, I conclude my talk. Uh, and further carry on with the discussion. we just go ahead with a panel discussion now. And just 3 seconds, I will just share the screen. I hope my screens are visible now.
Yes, sir. So just make it full screen now.
Yeah, is it now?
No, sir.
Full screen from my side.
Just unshare your screen and then reshare your screen, sir.
Now,
Yes, sir. Please start.
yeah. So I have my panel with me. So I do welcome again Dr. Amish sir. Sir, you are here.
No, sir. Dr. Amish is not here, sir.
Okay. And Dr. Anbarasan sir, are you here, sir?
Yeah, I'm here. Yes.
So I think only me and you are left in the panel, sir.
Oh, okay.
So the technical team, can you please connect with the Dr. Amish if he is available?
Sir, he has some work. He is not able to join again.
Okay. Sir, do you mind me continuing with the panel, sir, Dr. Anbarasan sir?
Yeah, we can continue with this. Yeah.
Sir, we have we have divided this panel into two parts, sir. One with the early breast cancer and one with the advanced breast cancer, particularly in the hormone positive subset per se. So just few the common questions are like in HR positive early breast cancer subset, what is the percentage which you see in your breast cancer clinic, sir? What comprises this subset of patients?
Yeah. Thank you, Kaushik. Regarding this hormone positive breast cancer subset, early breast cancer, which is without node positive disease, almost 30 to 35% will be there. And I think, yeah, 30 to 35 averagely around. And locally advanced around remaining 30 to 40%, and metastasis around 20 to 30% will be there.
So you have a fair chunk of around 30% of patients with the early breast cancer present.
Yes.
And what is the usual protocol in practice in your institution, sir?
So mostly these patients managed by the surgical team. So our institutional protocol is most of the early breast cancer patients handled by the surgeon. With the joints clinic discussion, they will go for surgery. Since it is an hormone positive cancer and early breast cancer, they undergo with the surgical plan, either with the mastectomy or with the breast conservation surgery. And after that, based on the histopathology report, we will finalize we will decide for the further chemotherapy plan and radiotherapy plan.
Fair enough. So basically, the importance is of with a multidisciplinary team, and we all know that there are studies which have shown that there is significant mortality benefit also with the discussion in the multidisciplinary team. And sir, your opinion regarding the risk of recurrences, the early and later recurrences in these hormone positive subsets. What is your comment on this pattern of recurrences seen, particularly in this HR positive subset?
Yeah. So risk of recurrence in any stage, it is devastating only. So whether it is early or it is a late recurrence, it is devastating. And this late recurrence we particularly see more in the hormone positive subset compared to other subset. So underlying pathology likely because the dormant cells which early metastasis before the uh, in even the early stage itself, it metastasis to various parts of the body, and it remains dormant for a period of time. And these dormant cancer cells are not exposed to chemotherapy, and they are mostly intrinsically resistant to chemotherapy and hormone therapy, and they manifest over a period of time. And early recurrence and late recurrence varies with definition to definition. Based on NCA guidelines, they term early, mid, and late recurrence. Early is less than 2 years recurrence, mid is 2 to 5 years recurrence, and late is more than 5 year recurrence. There are other retrospective studies based on Danish or Aryan population where they classified less than 5 years as early and more than 5 years late recurrences. And they analyzed what are the contributory factors for early and late recurrences. They analyzed clinical features, they analyzed molecular features, they analyzed immunological subset also in this population. One of the detailed study which I like to quote is NCCA based study where they analyzed early breast cancer patients based on all the clinical features as well as immunological markers and then molecular markers into the study design. In most of the time, early breast cancer patients will have larger tumor size, higher lymph nodal positivity rate will be there, and this most of the time they will have a higher grade, higher Nottingham score will be there. And for late breast cancer recurrence, they characteristic features phenotypically similar more or less to the long-term survivors only, and they have stronger hormone positivity will be there. And apart from other features, molecular features they describe, they analyzed gene expression profile alone, intrinsic gene expression profile, and they also analyzed amplification. What are the gene amplification rate? In that, they analyzed what are the different genes which are responsible for associated with cancer. Like, so there are certain genes which are associated with cell cycle. They analyzed those genes as well as other immunological genes also they analyzed. What they've seen is whenever there is an early onset recurrence is there, there is higher cell cycle dependent genes or levels are there, and those subset of patients have higher chance of recurrence, and these subset of genes are not seen in late onset recurrences.
Well said, sir. Well said. And as per endocrine sensitivity wise, if you can just enumerate your comments on the recurrences as per the endocrine sensitivity wise, sir.
Based on endocrine sensitivity, those who have late recurrences, they have high endocrine sensitivity, and they are more strongly ER positive. Some of PR sensitivity is not correlating much with the late onset recurrence, but ER has strong propensity. That is why the extended hormone therapy comes into picture. If the patient is side effects are very less, tolerance to the hormone therapy is very good, then we always consider for extended hormone therapy for the patient who are having strong hormone positivity.
Definitely, sir. As you said right way, and it is in the last year also. We know that those with highly sensitive have an extended disease interval, and lesser the sensitivity, then the DFI interval actually shortens up. You can see those with the moderately sensitive or moderate resistant, it's less than a year or something, and more of a visceral and extensive visceral medicine symptomatic presentation compared to the highly endosensitive population, which has more of a only bony metastasis. Rightly
Yes.
said, sir. And the risk of recurrence is as per the tumor characteristics of them. So we can see the options flashed off. You know, everything are important. Which according to you is the most important, sir, as per the tumor characteristics? Because this is the characters which has been taken by the major adjuvant trial of CDK4/6.
Sorry, can you please comment the question? I just missed the question.
Sir, regarding the risk of recurrences as per the tumor characteristics. As per the
So
tumor characteristics.
tumor characteristics. Yeah. So larger the tumor size, then there is a higher chance of recurrences. And if the patient is having more than 4 nodal disease positivities there, then there is higher chance of recurrences. There are studies they conducted based on the level of lymph node positivity and then assess the rate of recurrences. Whenever the higher nodal disease positivity is there, there are higher chance recurrence risk also very much higher. It reaches up to 40% also there. So these two comes into a higher chance of recurrence, followed by higher clinical grade. But in Indian subset, we don't have as such any data because most of the time what we see is higher grade only, and we see in a younger population. Age is also one risk factor for early onset recurrence. Younger the population, they have higher chance for earlier recurrence. And compared to Western world, we more frequently see younger patient in our population. So higher chance of younger recurrence we see. And other difference we see is late onset recurrences have better prognosis compared to early onset recurrences. And other thing is loco-regional disease is more common when the patient is having late recurrences. That is also one thing is there.
Rightly said, sir. Rightly, as you brought out, we don't have that data, which is the more factor into the tumor characteristics which is driving the recurrences. But each and every one are actually important. Be it the nodal status, the size of the tumor, grade, Even the molecular subtyping helps patient in correcting the
And one
grafting
more
test.
thing I would like to highlight is circulating tumor DNA. Currently, we are having running studies also there, because what they are suggesting is whenever the recurrence is there, the local disease may not be as effective as what we get. The molecular features will not be as similar as those in the metastatic site. And probably the circulating tumor DNA have a higher value in detecting all those characteristic features and deciding further therapy also. So probably in near future we may get data more regarding circulating tumor DNA, especially in this setting like late recurrences. We'll get more data.
Definitely, sir. It's coming up in a big way actually. Every other solid cancers also, there is a role of ctDNA evaluation looking at the distant recurrences. And looking for the initial talk which we had on Oncotype DX, so based on this, how important you do consider this genomic testing in the risk assessment in Indian clinical settings
Yes.
and your
So
practice?
yeah, genomic testing. One thing I would like to say is practice between Western world and here it is more different, because the cost of chemotherapy in Western world is much higher, whereas Indian setting it is very much lesser. We would like to thank all the pharmaceutical company for this, to bringing down this in a possible way for all the Indian patients, and that is one factor. And other thing is Oncotype DX. For them doing Oncotype DX and then going for a chemotherapy or no chemotherapy is more valuable for the patient, saving the time, saving the money, saving everything. But for Indian patients, doing an oncotype DX and then followed by cancer therapy is little bit difficult, cost concerning factor also. And we all know that most of our patients are below the poverty line and they depend most from the support from government scheme and other things. They require financial support. And even though these studies are very much validated, uh, problem from our side is we offer only to the patients who are very much affordable and who are well educated and know the exact importance of it. Then only we can able to describe these studies to the patients. And in my clinical practice, it is these patients are numbers are very less only because I'm practicing in a government sector, so these numbers are very less.
Definitely, sir. For us, the financial toxicity is the one which matters actually. So we can
Yes,
manage that
but even
even though.
still, we do get patients who are reasonably in this scenario, like postmenopausal patients with tumor size of 3 to 4 centimeter with node negativity status. We do recommend, and they also consider these scenarios. And upcomingly, patients are well aware of all these situations, and they are also educated about these scenarios. And healthy discussion makes them to aware of this thing, and we make you utility of this test also.
Sir, regarding the Indian the CANSS program, CANSS test, any experience in this CANSS?
Uh, so far, we prefer, if we want to do genotypic assessment, definitely we prefer for the test which has a higher validity like Oncotype DX, because it has run through a valid study. But other CAN assistant we prefer much lesser, because it has not based on any prospective study design. It all based on a retrospective study design for a limited duration of time. That is the reason why we not prefer much for a CAN assist study design. And even endopredict score is also there. Even that has shown it has a very good negative predictive value. If it is negative, then it is negative. But if it is positive, we are not very sure whether it turns to be positive or negative. That risk is there. And other major change why we don't use genomic testing is most of the time in Western world, the breast cancer detected or screening detected population. Whereas in India, most of the patients are advanced stage only. So most of the time they came in a very advanced stage where these type of tests may not be helpful for them. That is the scenario we run through in our routine day-to-day practice.
Absolutely, absolutely agreed upon. Based on the CANSS, though the cost is actually accessible presently, but we need more validation data. Actually.
Yes, other thing also young subset of population in the oncotype DX also the numbers are very less. I think around 5 to 10% below the age of 35 to 40 years. We see more of those patients in our Indian setting. So that is also one differential factor we would like to consider. Definitely in younger patient, I have a thought before prescribing for oncotype DX because of the surrounding situations. If it is an older postmenopausal female, definitely affordable, then we consider for this type of testing.
Definitely, definitely. So just a few discussions on the metastatic breast cancer setting. So in this setting, what do you consider is the primary treatment goal? What the patient expects and what do you expect? What is the treatment goal here in this setting of advanced breast
So
cancer?
in every setting, we put patient first. Like quality of life of the patient is much more important, and whatever the treatment is there with minimal side effects, with a healthy life and lesser hospital time is our first preference. Following which, the next preference is for overall survival. So if these two things are manageable, then we consider, and there will be, if the OS is significantly better with a particular agent, then with quality of life, minimal compromise also, we tend to prefer for the patient. Definitely,
Yeah,
these two comes into a picture compared to PFS and response rate.
definitely. And this was an interesting study which was published in BMC which showed that in the physician survey which has been seen against the, as you said, it was the prolonged life and the quality of life which ranked upper compared to other symptomatic relief or tumor shrinkage or a delay in chemotherapy, which mattered. And even with the per se, the patient per se, the most of them were willing to trade off for the side effects of treatment against the prolonging of the increase in the quality of life or the length and overall survival which has been seen. They were this was the from the patient perspective per se. So OS and PFS always we have the debate which is the endpoint and whether the PFS can be a surrogate to the the OS is the gold standard. Your comments on
Yeah, it's actually healthy debate to have. In recent scenario, to be very honest, the trend is more towards paths here. So when we see newer drugs upcoming, there is our certain places we see paths here as a criteria is also there, and it's a healthy discussion. It varies from place to places also, because sometimes what happens there when there is multiple lines of treatment options are available, then PFS might be a misleading factor. OS might be a misleading factor also because of multiple lines of agent. Then a subsequent line might increase this thing survival also. So we need to analyze according to case basis. If it is a TNBC, definitely overall survival is one factor we need to depend on because it is very shorter duration. In case of early hormone positive breast cancer, then overall survival has an advantage, but still PFS also plays a role because of multiple lines of therapy in there.
definitely, sir. We know that OS can be beat upon. It's been a gold standard and most reliable the endpoint, which has been shown to be have a meaningful improvement and the improvement in the quality of life. And this was one of the data which found that in this coefficient analysis compared to the PFS versus OS, we have seen that the uh, approximation of the PFS towards the OS was very modest. In the major of around 72 trials based on the chemotherapy, there's been only 30% correlation with the PFS and OS here. And they also had a DFS analysis that's been seen, but there's been seen more than the PFS. It was the DFS which was more of a surrogate towards the OS in this setting of population and DFS and also the invasive digital survival. So there was more of and presently the data is also a bit of evolving, the new papers coming up with being more of an approximate surrogate towards the OS in this set of patients. So your analysis based on this invasive disease-free survival, sir. Any comment?
Invasive disease-free survival, yes, I would like to consider because maybe the question is pertaining to the use of CDK4/6 inhibitors and early breast cancer setting. Yes, definitely yes, because the data is very good. 5 to 6% benefit, keeping in mind that a high risk population because most of them are high nodal disease burden and most of the patient have high tumor grade. Definitely, it's a very good subset. With the difference is there. Definitely, I would like to go ahead with the IDFS advantage also for those patients
So the
because
last,
always treating a metastatic setting is very difficult. It is not a curable disease. So in early breast cancer setting, IDFS definitely I go ahead with the therapy.
rightly said. And just coming to the last of the discussion against all these CDK4/6 inhibitors, we have seen in the adjuvant setting we have three CDK4/6 inhibitors. Still, the results are different. The OS and PFS benefits which have been seen are different. So, your comment on are these inhibitors the same, whether these are the class effect or they have their separate PKPD analysis? So, your thoughts on all these three situations?
Yeah. So yes, definitely all these molecules are not very same in terms of benefit toxicity profile. It is different only because even in pharmacological action also we see abemaciclib can be given continuously, whereas ribo and palbociclib need a break because of the more propensity for CDK4 than CD6 action. So there is a pharmacological difference is there, and the drug potency wise also it is different. Side effect profile wise it is different. Ribociclib have more liver related toxicity is more common. So abemaciclib will cause more of a diarrhea. Neutropenia is more common with the ribo as well as palbociclib we see. So side effect profile is also different. When we see in metastatic setting, Mona Lisa 2 trial, which shown a good OS advantage also, where the median OS for 64 months when the patient taken ribociclib, whereas it is only around 50 months when the patient has not taken ribociclib. There is almost 12 to 13 months benefit was seen with ribociclib. And whereas Palamo trial failed to show any OS benefit in this scenario, whereas abemaciclib also showing some amount of benefit is there. And ribociclib after a period of usage, we see patients having more tolerance and side effect profile also be able to manage in a better way. So I feel there is a slight differences there among all TKI, and even the guidelines which we say based on the MAS guidelines or ESMO guidelines also, the option has been tilted more towards for a ribociclib as a category 1 indication. Previously, it was all CDK4 inhibitors has been placed in a category 1 indication for metastatic breast cancer setting. But over a period of time, with more amount of clinical data available, the thing has been shuffled. Ribociclib has given priority compared to other things between a lower setting. So I do there is differences there in both in terms of efficacy as well as toxicity. It is agreed all over, and it is generally agreed by the guidelines also.
Definitely, then, as you said, rightly brought out, we can see just the kinase inhibitor profile is entirely different. Like ribociclib and palbociclib, off-target kinase activity is almost similar compared to the abemaciclib, which has more of a off-kinase activity. And also, in the Mona Lisa data we have seen that ribo has consistent OS benefit in this luminal line and HER2 subtype across the subtypes of luminal A, luminal B, and HER2 ribociclib has shown the OS benefit. And one interesting what I thought was seen was the change in the tumor biology. Sir. Like over here, if you see the natural tumor biology with normal disease progression, majority of basal-like it remains basal-like and HER2 enriched remains, but the luminal B changes towards the HER2 enriched or the more aggressive one, and luminal A gradually as the tumor progresses changes. But it was seen that with the presumed treatment of CDK4/6 inhibitor, the change from the luminal A towards the luminal B or the aggressive is a bit limited, and there is reverse changing from the luminal B towards the luminal A, with the less aggressive subtype. There's a tumor biology they hypothesized with the continued CDK4/6 inhibition. And also, as you said, the more of a important role in the CDK4 compared to the CDK6 inhibition, and head-to-head comparison with all these three, the differential activity both on the biochemical and the cell line, more of a CDK4 inhibition, the ribociclib and abemaciclib compared to the palbociclib arm. Of kinase activity again different for all those three. And in this snapshot, you can see that more of a potency which was seen in the ribociclib with the dose for the standard metastatic breast cancer dose which we used. The steady state concentration was also, and the free drug exposure was the higher side for the ribociclib compared to the abemaciclib and the palbociclib. So every three has a unique PKPD characteristic per se. So concluding here, sir, just we know that the CDK4 are here to revolutionalize the treatment in the management of breast cancers, and endocrine therapy has been changed. The only what we had on for the last 2 decades, it is actually changing in the management of particularly in the early breast cancer subset, and we have seen the benefits which has been clinically seen with all these three drug classes. And also, it's not a class effect. The drug has their own unique activity we have discussed right now, and future developments may benefit more patients in subset of patients with early breast cancer. So your final comment on the role of these in the early breast cancer subsection and your day-to-day practice, do you usually recommend these adjuvant CDK4/6 inhibitors those patients who are setting in these inclusion criteria of these trials?
Yes, I'm started to practice because after seeing this ESMO guidelines and also in Indian Cancer Congress, they presented the final data for say CDK4 inhibitors, especially abemaciclib. I started to practice based on the high risk criteria. I definitely prefer after counseling this patient because of very good DFS advantages there. Yes.
So thank you, sir.
And
And anything
we,
you want to?
yeah,
Yes, sir.
correct.
Please
We
go
go.
on. Please go on, sir.
And
Anything finally you want to say?
And yeah, ribociclib also we do prefer after this Natalie study design. When the patient high risk feature is there, when they are not feasible, when they are not fit enough for chemotherapy, we do often try ribociclib because we always have a good amount of long term usage data with ribociclib is there. Where we also tried ribociclib in this scenario also.
Definitely, sir. It seems interesting, like how it usually evolves later on, because we know we are using this in the early breast cancer setting, and we don't have any data on re-exposure of the CDK4/6 inhibitor once the disease progresses and they
Mhm.
land up in the metastatic breast setting. So it's interesting how it actually evolves in the next decades. So interesting to wait and watch and to learn. And thank you, sir. Thank you for being a part of this discussion. And thank you very much. And thank you very much, all the participants over here and all the attendees over here. Thank you, sir.
Thank you. Thank you for
Thank
the
you, all.
wonderful panel discussion. Thank you, everyone. Yeah.
Thank you, sir. Organizers, you can take over.
Thank you, Dr. Kaushik. If there are no further questions, we can close the meeting.
Thank you.
Thank you.